So here we are to talk about drugs used to manage GI disorders, one of my favorite topics of conversation, and one of my favorite little cartoons to start off the conversation. So GI disorders, it really comes down to just a couple of targets of treatment. Okay, now my slide has finally switched. Okay, so you know how we always review the relevant physiology, like what we're doing to the body with the drugs. And with the gut, there's just a couple of them, motility and acid secretion. Remember, the gut's primary job is to allow you to ingest fuel sources, break them down, absorb the fuels, compact the waste, and excrete it out the other end. And in order to do that, this gastrointestinal tract has to be capable of movement or motility, forcing the food bolus from the top to the bottom with just the right amount of time in each spot. That's the motility issue. And then the secretion issue is the secretion of acid and the appropriate enzymes that facilitate breakdown and absorption of the food. So this diagram here, very simple one, but it represents motility. And this is just designed to show you the differences. I mean, it is just one long big tube, right? If you took it from mouth to anus and stretched it out, it would just be one long muscular pipe. But that muscular pipe is comprised of many different types of muscle. Excuse me. Because each section of the GI tract has something different to do and it moves at a different rate of speed. The esophagus is very muscular and very forceful, and that's because it has to take the swallowed food bolus and move it from the top of your esophagus to the bottom of your esophagus in one good, strong contraction. You know, food doesn't sit around the esophagus, right? You swallow and it goes from top to bottom, and that's like at least like a foot, right? It has to move through a foot of muscle, really, in just a second or two. So you've got like long, skinny, longitudinal muscle that just squeezes and pushes that food from top to bottom. Every once in a blue moon, we've all had that experience of like food getting stuck. And that means it didn't go all the way down. And when that happens, usually just the presence of the food in the middle of the esophagus, distending that muscle, triggers another contraction, and a spontaneous contraction will occur and get the food down. Just, excuse me, as a point of interest, the very last thing you want to do when you feel like food is stuck in your esophagus is to pound on your chest with your fist, which is what everybody does. But what that actually can do is cause reflex contraction of the muscle, so it'll like hold on to the food more. So if you feel like something is stuck in your esophagus, the thing to do is voluntarily swallow again, because that facilitates that longitudinal contraction of that muscle. And if you repeatedly feel like stuff is getting stuck in your esophagus, then you have a motility problem and it's time to go see a gastroenterologist. Just a little aside. But the pertinent point here is food has to move out of the esophagus quick, from top to bottom, usually in one fell swoop. That's the character of that muscle, and that's what it does. Then when it gets in the stomach, it's the opposite. Food stays in the stomach for a couple of hours so that that food bolus can be broken down and all of the component parts of fuels taken out of it. It's getting ready for absorption. So food like stays in the stomach, and the stomach like squeezes around from the proximal end, pushes the food to the end of the stomach, but it's like a closed loop in the beginning, and the food bounces back, and that's how you just get progressive mixing in the stomach. And then it very slowly shoots through the pyloric sphincter into the duodenum. Now the duodenum is just the opposite of the esophagus. Duodenal contraction is very slow and minuscule because food I just think of it as like marching along like ants, because you want this digested bolus to stay in there for a while so that all the appropriate nutrients can be absorbed from it. The jejunum and the ileum are similar. There's certainly absorption that goes on in the jejunum. The ileum becomes more about water reabsorption. Like by the time food gets to the ileum, most of the nutrients have been absorbed, and now you just have to reabsorb water and form your waste. And then by the time it gets to the colon's job also is reabsorption of water that hasn't been reabsorbed already and formation of the waste bolus to be excreted at the other end. And if everything was perfect and we all ate a perfect diet and we all had perfect bodies, then every morning at 7 a.m. we would eliminate a perfect little hunk of excretion with no problem. But of course, that is hardly always the case. But that's the way it goes. So the thing is, even though this is just a big muscle and it's moving food from the beginning to the end, At different stages of the way, it works at different rates of speed. So various disorders or GI complaints are a consequence of things either being speeded up or things moving too slow. If the esophagus moves too slow, you have a sense of persistent food getting stuck, and that's a condition called achalasia. If the stomach moves too slowly, then stuff doesn't get mixed properly, and you'll have impaired absorption in the duodenum. If the duodenum moves too slow, believe it or not, I mean, we talked about this actually the first week. Sometimes if things sit there too long, they undergo too much degradation and you can't maximally absorb. On the other hand, some things sit there longer and it just facilitates absorption. So you don't know exactly what's happening in terms of nutrients, but you know it's changed in some way. And then if stuff moves too slowly through the jejunum and the ileum, you have too much water absorption. The stool winds up too hard and you wind up constipated. And of course, if the colon is slow, wind up constipated. In the total, converse relationship, if everything is moving too fast through the stomach, duodenum, jejunum, etc., well, then you don't have time to absorb your nutrients and you don't have time to absorb your water. And what you wind up with is liquid diarrhea, several a day. And if this goes on chronically and you really can't absorb nutrients, there's all sorts of nutritional deficiencies that can occur. So when we are trying to treat chronic diarrhea or chronic constipation, often what we do, or even acute for that matter, I shouldn't just say chronic, when we're trying to give drugs for constipation or diarrhea, usually what we're doing is trying to impact motility in some way. So, there we go. Drugs that treat GI disorders largely fall into two categories: those that inhibit motility, and there are those that increase GI motility, although that's just more specific. We don't have as much reason to do that. I mean, well, we'll talk about it in a little bit. And then those that affect acid secretion, because acid secretion is also a big part of symptoms in the GI tract. So generally speaking, and there are a few exceptions, but most of our drugs are either going to, I should say, affect motility more than inhibit motility. The better phrase there is affect motility and affect acid secretion. All right, so let's see. I had started to talk about this. Constipation and diarrhea are typically a consequence of either decreased or increased motility. The gut is moving too slow or the gut is moving too fast. And lots of different things can affect this. So the next bullet point says a variety of factors can slow motility, and that's very true. Drug effects. There are lots of drugs that slow down GI motility. Some of them we do it on purpose. Like when you have diarrhea, we will purposely give the patient a drug to slow motility, slow things down, allow them to absorb that water. But then there are other drugs where an unintended effect is a slowing of motility. And the two classic ones right off the top of my head are anticholinergic medications, and we've talked about anticholinergics. The cholinergic system is the one that really drives GI motility, right? The parasympathetics really drive GI motility. And the primary neurotransmitter of the parasympathetic system is acetylcholine. So if we give an anticholinergic or anti-acetylcholine, it will slow down the drug. It'll slow down the gut. Opiate analgesia, morphine, Dilaudid, hydrocodone, all of those opiates are anticholinergics, and there's like a big issue with opiate-induced constipation. It causes the constipation because it slows down GI motility. First-generation antihistamines are also big offenders for causing constipation. Things like Benadryl, like people that take every night, they take an over-the-counter sleeper like Tylenol PM or Excedrin PM. Those drugs have from 25 to 50 milligrams of diphenhydramine in it. If you take it every day, there is definitely the potential to inhibit bowel motility in the morning. Another big class of drugs that slows down GI motility are drugs that are used for urinary incontinence, like Vesicare and Ditropan, and there's a ton of them. Those are the first two I can think of off the top of my head. But the point of those drugs is to slow down cholinergic activity in the bladder, but they always have the unintended consequence of slowing down cholinergic activity in the gut. So there are lots of drugs that we use that can slow down GI motility. Sometimes it's our intended purpose, and sometimes it's a side effect. Those of you that have taken care of patients in the hospital that are on opiates got to know what I'm talking about. More than half of them get constipated from it. Aside from that, excuse me, just being immobile, just being bedridden can facilitate constipation. So patients who are bedridden because of a lengthy illness or like a long recovery from a major surgery, an orthopedic surgery, or just people that as a consequence of increasing frailty become immobile can have problems with constipation. And again, you know this with your frail elders. The less you move, the less your gut moves. Volume contraction, good old-fashioned dehydration. People that get dehydrated from like sepsis and, chronic, like they're diaphoretic, or people that are just dehydrated because maybe in the outpatient world, they're like alcoholics, really poor nutrition, don't pay attention to themselves. Sometimes, especially older people who are really prone to changes in volume status, if they just have bad diarrhea or like a couple of days of vomiting, they will get dehydrated enough to get constipated. And then many diseases cause gastroparesis, or like a slowdown of the gastric system, like diabetes can cause gastroparesis. There's also a phenomenon called post-viral gastroparesis that you will see most often in middle-aged women after bouts of serious gastroenteritis. Like this happened, like that cruise ship virus, the Norwalk virus, where people go on a cruise ship and then they barf their brains out for 2 days. Often, not often, but sometimes people afterward will have this phenomenon of post-viral gastroparesis where the gut just sort of temporarily paralyzes, and so it slows down. So anyways, primary point here is there's lots of things that can facilitate constipation. Similarly, a variety of factors can increase GI motility. There are certainly medications that can speed up the gut. Reglon is one of them, and Propulsid is another one. We don't use Propulsid as much anymore. It's not widely available, but it is a GI motility agent. And then there are GI motility agents that are used for irritable bowel syndrome, and we'll talk about more towards the end of this slide set. But those are drugs that increase serotonin activity in the gut because your serotonin is another major neurotransmitter that causes peristalsis in the gut. Also, cholinergic medications, drugs that activate the cholinergic system or increase the amount of acetylcholine. And the primary drugs that we use therapeutically are the cholinesterase inhibitors of Alzheimer's disease. Drugs like Aricept, Exelon, Razidine. These are all drugs that increase acetylcholine in the brain because that helps memory in Alzheimer's, but they also, unintentionally increase acetylcholine in the gut and can cause diarrhea. So there are some drugs, just like with drugs that slow down the gut, there are some drugs we give purposefully to speed up the gut, like we do in irritable bowel, and then there are some drugs that unintentionally will speed up the gut and are side effects. Diarrhea will be side effects of medications. There are also functional bowel diseases that can change GI motility, and these are called irritable bowel syndromes, or IBS. IBS is a functional motility disorder that can result in either a marked slowing of the gut, and then you'll get constipation, or marked acceleration of GI motility, and you'll get diarrhea. And you may have come across these. They're referred to as IBS-C, which is irritable bowel syndrome constipation, IBS-D, which is irritable bowel syndrome diarrhea, and then some unfortunate souls have IBS-M, which is mixed, or some people call it -U, which is undifferentiated, which means those poor folks have like alternating periods of extreme constipation and extreme diarrhea. And it can be lifestyle inhibiting. I mean, it can be reasons that people can't leave the house when they're in a bout of diarrhea. And when they have IBS constipation, they can go days and days without a bowel movement. There's a whole group of medications that are designed just to treat the GI, the motility issues of irritable bowel syndrome. And again, we'll talk about them when we get to medication specifically. Chronic infectious diseases of the gut, especially people that have immunosuppression, will sometimes have like chronic fungal overgrowth and they just can't absorb, and so everything that they ingest kind of comes out, water included, and they wind up with chronic diarrhea. And then autoimmune disease. There is a family of autoimmune diseases that affect the gut. These are called inflammatory bowel diseases, or IBDs. It's easy to mix them up with the functional bowel disease, IBS, but don't do that because they're very, very different things. IBS is a functional bowel disease, and it's just about motility, too fast or too slow. Autoimmune disease, inflammatory bowel disease, or IBD, it's a systemic autoimmune disease. It can affect lots of areas of the body, but one of them is the gut, and it actually causes ulcerations along the intestine and the bowel. The two you might know are ulcerative colitis and Crohn's disease, and those are autoimmune diseases of the gut. One difference between them and the functional bowels is that the functional bowel diseases, because they are specifically about motility, they can either slow down or speed up the gut. You can get constipation or diarrhea. Autoimmune disease that causes these ulcerations in the gut, these just inhibit absorption, so nothing gets absorbed right, so the consequence is diarrhea. So the bottom line is this autoimmune IBD will only cause diarrhea. Now sometimes it is horrible. I mean, the gut's just so ulcerated and stuff pours out, and people have to have diverting ileostomies and stuff just to get a chance for their gut to rest. But autoimmune disease, when it affects the gut, it's just about diarrhea, whereas functional bowel disease can go either way. So, medications that treat these disorders are typically those that either slow down motility or speed it up. So keep that in mind. Now we're going to take a few slides to look at gastric acid secretion, and then we'll jump into the drugs. So now disorders of gastric acid are the other thing that we typically manipulate with pharmacotherapy. And the ones you're probably most familiar with are things like peptic ulcer disease, right? People that have ulcers, gastroesophageal reflux disease, and gastritis. These are the primary things that you will see people getting drugs for that change the way the gut produces gastric acid. And so these are like, there are a couple of very different diseases, and we want to affect them in different ways. But what we're doing here is manipulating production of acid. So let's look for a minute at acid production. So in the gut, you know that you have parietal cells, and within the parietal cells, like they line the inner surface of the GI mucosa, and they do lots of important things. One of them is the production of acid. Remember, you have to have a lot of acid in your gut. The acidity, the pH of your stomach is somewhere between 4 and 5, which is much more acid than the rest of your body. You know, if you've ever interpreted a blood gas, the normal pH of your blood is 7.4. The normal intracellular pH is 7.0. The pH in your gut is between 4 and 5. So that gives you some perspective on how acidic the gut is, because that's how you maximally break down food boluses and absorb the nutrients from them. And in order to maintain that really acidic environment in the gut, you have to have all of these acid pumps that are constantly making acid in the form of hydrogen ions and shoving them into the lumen of your gut. And these pumps are in the parietal cell. So the parietal cell, it's a cell, it's got a nucleus, organelles, and does lots of different things. And one of them is maintenance of the proton pump. And this is proton with a capital P, like the proton pump. The whole job of the proton pump is to push acid into your gut against its concentration gradient. Remember those basic concepts of diffusion, right? Osmosis and diffusion. Your body likes things to be equal. So if the pH inside a cell, like the pH inside your gastric cell, is 7, and the pH in the gut outside of your gastric cell is 4, it wouldn't make sense for you to keep pouring more and more acid out into the gut. Your body's natural inclination is that everything should be equal. But since the gut can't work right that way, you've got to have these proton pumps, which are these energy-requiring active transport pumps that are constantly pumping acid into the gut to pump more and more in there. And there are 4 phases of acid secretion. And they're important because we want to, in order to give drugs right and have them work the best and work maximally, it needs to be timed right. And this is actually a really important nursing implication. And so here's the pump. Here's what it looks like. So this is a collection of cells. But the cell, so My brain is moving too fast for my mouth. Let me back up a little bit. This is the layer of the cells that's on the innermost aspect of your gut. So like, I'm going to label one side of it number 1. Number 1, this is the lumen of your gut. This is like the cavity of your stomach. This is, you know, the hollow of the stomach where food plops in after you eat it. And it's lined with these cells. Then on the other side of the cells, which I'll label as number 2, this is like deep into the musculature of your gut. It's not pictured here, but in number 2, there's other cells that are mostly muscle cells that aid in contraction. But this group or this line of cells that is at the innermost lining of your stomach are the cells that make the acid, the parietal cells, and the cells that make the mucus that protect you. Because like in an odd way, you've got these parietal cells, also referred to as oxyntic cells, and I'm underlining that. These are the cells, and like there's a cell, I'm outlining it in red. Once upon a time I thought you could see me drawing, and then I realized you can't. But you see where I have the line, oh, phooey. Never said I was an artist. Let me try this again. You can see where I put a line under the word oxyntic. That's also the parietal cell. 2 words, 1 thing, just the way the body is. And then where you see the red, you know, the red lines under from oxyntic cell, that's your parietal cell. And inside the parietal cell is the proton pump. And I'm going to label that as a 3. And the proton pump makes acid and secretes it into the cavity of your stomach, and that's where I've drawn this giant hydrogen ion. Okay, since you're putting so much acid into your stomach, it would actually burn your own cells. The way you protect yourself from that is by making mucus, and mucus is made by the mucus neck cells, so I'm going to underline the word mucus in blue. And oh no, I thought I was going to underline it in blue. I guess I didn't. Let me try this again. Blue pen. Let me see if this works. Yep. Okay, so mucus is underlined in blue. And then there are 2 mucus cells shown here. And you can see I drew squiggly lines to each one of them. Their job is to make mucus. They make mucus that lines, and I'm just drawing a bunch of bumps here. The mucus lines the whole inner surface of the gut. I never said I was an artist, but, oh God, I really blew that. But mucus lines the whole inner surface of the gut so that the acid you produced doesn't burn you. It's sort of a convoluted system, but you want the acid that you made not to burn you. So you've got these cells working together to put acid in your gut, but not burn your own stomach cells, okay? But the important thing is that the proton pump is, oh, I really messed up my, okay. The proton pump is in here making acid and secreting it, okay. If we want to change GI acid concentration, we have to interfere with that pump in some way. I think the next slide just shows this up close and personal. Yeah, like, here you go. So this is the proton pump. This whole thing is happening inside that parietal cell. And the only thing that really matters here, this is actually like a microscopic version of what we just saw in the other cell. This is the other picture. This is the lumen of the canaliculus, or the hollow of your gut. This is the part of your stomach, you know, where food actually goes in. This is, number 2, is that first layer of cells where the mucus cells and the parietal cells are. Well, now we're inside the parietal cell. And then what I'm labeling as 3 is deep in the muscle of the gut. Like this is the fluid between the parietal cell and the muscle cell behind it. All this is showing you is how many processes with different electrolyte pumps come into play in order to allow for 155 milliequivalents of hydrogen to get into the lumen of the gut. This whole thing, all these different sodiums and potassiums and bicarb and CO2 and water movement and chloride and all this kind of stuff, they all drive the proton pump. And the proton pump is the thing that I'm going to outline in blue. I mean, the whole thing is the proton pump, but at the end of the road, this is what pushes all that hydrogen ion out into the lumen of the gut. That's the proton pump, and that's the thing that we're gonna treat when we give medications. So that is the proton pump, and I know you know proton pump inhibitors. This is the proton pump. This is a thing we're gonna target with treatment. So there are 4 phases of acid secretion. That proton pump, obviously it's not maximally putting out acid like all day and night, or otherwise you would be so full of acid, you know, that you would burn a hole in every structure in your gut, because nobody can take that much acid. You don't need that much acid in your gut all the time. So acid production goes through phases. The first one is the basal phase, also known as the interdigestive phase. This is the time like when there are long periods of time that you're not eating. This is baseline. This is typically overnight. You know, you eat dinner at whatever time, 6, 7, or 8, and then presumably you don't eat again through the evening. I mean, maybe you eat a snack, but you probably shouldn't. But anyway, you ate dinner, and then you're done most of your eating for the night. And you're going to be up for a few hours, and you're going to go to bed. And all night long, you're going to sleep and not eat anything. Obviously, you don't need maximal acid output at this point. You need basal acid output. The proton pump is functioning from 0 to 30% of its potential at that time. And the proton pump at this point is stimulated primarily by 2 neurotransmitters, acetylcholine and histamine. That's what really matters to us. So there's low levels of acetylcholine, lower levels of histamine, and then there are also inhibitory factors. They all conspire to keep your output between 0 and 30% of its max. So if each proton pump could put out 10 moles of acid, and I have no idea, I'm just making that up to illustrate my point. If each proton pump could put out 10 moles of acid, in the basal phase, you'd be putting out between 0 and 3. Then the cephalic phase is the next day. You wake up in the morning, right? You're hungry. You haven't eaten all night. Your head is in food. I mean, most of our heads are in food. You're designed to be that way anyway. You are designed to wake up hungry. So when you're hungry, your body reasonably anticipates that you're going to start eating pretty soon, right? So you now enter the cephalic phase of gastric acid output. Your body is preparing to eat. So if you see food or you smell food or you even start thinking about food, your stomach is going to start to crank up its motility and crank up its acid production. See, remember vagal system is the parasympathetic nervous system. This is acetylcholine. You have acetylcholine stimulation of parietal cells that will make the acid, and vagal stimulation of antral cells that will start contracting. What happens when you wake up hungry and start thinking about food or smell food or even look at it? Your stomach starts to growl, right? Your motility is cranking up, your acid is producing, you are ready to eat. Here you are like much past 30% acid output. Now your acid output really begins to crank. Then your nirvana, you eat. The gastric phase is entry of food into the stomach. Obviously, the point at which food goes into your stomach is when you need maximal acid output. Because number one, there's food coming in right away that's going to have to be digested. So you're going to have your maximally acidic environment to break down the food bolus. And at the same time, just the very act of putting food in your gut raises the pH. I mean, it neutralizes the acid that's in there. So when you start dumping food in your stomach, you need more acid and you're buffering the acid you have. So now the parietal cells really crank up, approaching 100% of their maximal output. These proton pumps are stimulated by the chemicals of food release. They're stimulated by chemicals from your nervous system. And just distending the stomach with food triggers a vasovagal reflex that will increase contraction and increase acid production. So the point is, during the gastric phase, when food is in the stomach, your proton pumps are at their maximal production. And then the intestinal phase is when the food bolus has passed out of the stomach and into the intestine. So think about logically what's happening now. You're done eating. You've finished eating. Now you are digesting what you ate. your stomach can reasonably assume that you're not going to eat again for a very long time. And it hopes you're not anyway. But, from a purely physiologic perspective, we are not designed to eat when we're full. We're not designed to eat when we've just eaten. So since you're not designed to be eating, one of the first things that happens is that you will suppress gastric acid production. Now your acid output is less than 10% max. So remember my example, if you could produce 10 moles of hydrogen ions per parietal cell, now you're down to less than 1. You're not making acid. Your stomach doesn't think you're going to need it. Stomach is not contracting because, again, you've already pushed the food bolus into your intestine. Now you're into the intestinal phase. The stomach is actually shutting down until it thinks it's time for you to eat again, which are going to be many hours away. There are actually things that happen at this point that purposefully suppress acid production, like somatostatin, which is growth hormone. As your stomach empties, you just can't buffer as effectively. These things just all conspire to slow down acidity. So the bottom line is, what I want you to take away from these few slides is there are 4 phases of acid production. The first one is the basal phase, say when you're sleeping and you don't need that much acid, so your proton pumps are working at less than 30% their ability. Then when you wake up after a fast, you don't have to have slept, but anytime after a long fast, when your stomach is ready to eat, you enter the cephalic phase where you start thinking about food, maybe you see it or smell it, your stomach cranks up, getting you ready to eat, and you increase your acid output. And then you eat. And when you actually have food in your stomach, this is the gastric phase, that's when your acid production is in highest gear, approaching 100% of capability. And then after you're done eating and you're digesting, you're in the digestive phase, your stomach doesn't need acid for a while, so you slow down to less than 10%. We need to keep that in mind because when we give patients drugs that affect acid production, we have to think about where they are in the phases of acid production. And then finally, we can't ignore the little mucosal barrier. There are those oxyntic cells that actually make mucus, and not the oxyntic cells, the mucus goblet cells, and they make mucus that will protect your stomach from all this acid. So with all of that in mind, motility and acid production, let's take a look at some drugs. Drugs used to manage GI disorders. Whoopee. So first we'll talk about drugs that are used to manage diarrhea. And if you keep in mind that diarrhea occurs primarily when the gut is moving too fast, when GI motility is increased, which means you don't have the opportunity to reabsorb water. So the stool is watery and it's coming out faster than it's supposed to. The logical way to treat this is to slow down GI motility. And that's what our most effective drugs do. Just as an aside, I know that this isn't your decision in terms of prescribing, someone else is doing the prescribing, but most of these drugs for diarrhea are PRN, and you might want to talk with your patients about the fact that when the body acutely speeds up motility, like when you get acute diarrhea, like the jet-propelled 15 watery stools a day kind of diarrhea, it's almost always because something has been introduced to the GI tract that your body wants to get rid of. A virus, a bacteria, something in there that doesn't belong, and your gut is protecting itself by trying to get rid of it. Most of the time, people with acute diarrhea are really better off just letting it run its course because it's usually be really bad for a day, and then the next day it'll still be there but not quite as bad. And by day 3 or 4 it begins to get manageable. That's because the body is usually protecting itself. Yes, we can give powerful medications to slow down the motility, and their diarrhea will slow down, but what you're also doing is allowing the stuff that the body wants to get rid of to stay in there. So, like in the case of Giardia, I don't know if any of you have ever had the privilege of a Giardia infection. Giardia is a waterborne protozoan. I got it years ago water rafting down the Colorado River, and it really upsets the gut. And when it gets inside, your body doesn't want it there. It wants it out. It knows that if the Giardia gets to stay inside, if it stays in there too long, it can burrow itself into the wall of the mucosa, and then it hangs around, and it's really hard to get rid of. So when your body perceives Giardia, it will crank up your gut hugely motility to get it out. The best thing to do is just let it come out. If you give something to slow down motility, you allow the organism to stay inside longer, and then most people will be okay, but maybe somebody won't. Somebody will get, like, they wind up getting the Giardia in the lumen of the gut, and then they need luminal drugs, and it's just a big pain in the neck. So bottom line is, usually when you get that acute jet-propelled diarrhea, the body is trying to get something out. If you feel compelled to inhibit it, we do it by inhibiting motility. Bismuth is Pepto-Bismol. Lomotil is an anticholinergic. I mean, that's how it works. Lomotil and Imodium, they slow down acetylcholine-mediated motility. Opium, I don't know anybody giving opium anymore for diarrhea, but opium is like the prototype opiate drug, right? I mean, talk about slow you down. And paregoric is an old-time opiate-based anti-motility agent. But that's the way, you know, if you get this acute stuff, like you ate some bad buffet and the next day you can't get off the toilet, no control over it. If you got to treat it, and you're better off not, but if you got to treat it, you need to use a motility inhibitor. The other drugs that we use to treat diarrhea are the bulk formers. And so these are things like Fibercon, Metamucil, you know, there's a ton of them out there. What they do is just bulk things up. I mean, they're fiber, they're like a sponge. You know, this is like powdery stuff. You take a tablespoon in water or something like that, and you put it in the gut, and like a sponge, it just absorbs the water. So it truly, like the name implies, tries to bulk up the stool a little bit. I mean, it doesn't give you a good form stool. It kind of gives you like Jello instead of water. It slows things down. This is safer. Actually, let me go to the next slide. Yeah, it just bulks. It's like a sponge absorbing the water. So it's safer in that it's not absorbed in your body. It doesn't slow down the motility. I mean, the problem with giving a motility inhibitor is it's very effective, but it's going to slow down motility all over your gut, including your esophagus and your stomach and all the other places you don't necessarily want to slow down. It's going to dry out your mouth. It just interferes with digestion all across the system. The bulk formers, on the other hand, don't do that. They don't inhibit motility at all. All they do is absorb water in your gut and try to bulk up your stool. So they're safer, but they're not as effective. So the bottom line is the bulk formers are not what you use when you wake up, you know, for a day where you're going to have to be in the bathroom 15 times and like can't go to work because of it and all that. Bulk formers are for people with like chronic diarrhea, more like that irritable bowel syndrome that we're going to talk about a little bit later. Chronic diarrhea problem. You know, diarrhea means many things to many people. Some people will say they have diarrhea when they're having like a loose stool, or like they might have 2 loose stools a day and call it diarrhea, whereas somebody else might not call it diarrhea until it is 10 to 15 watery, like, you know, burn your anus kind of diarrhea. The bulk formers are more appropriate for those 1 to 2 loose stools a day. They're safer, so they're good, but they're just not as effective for the big stuff. The really big stuff, you need the motility inhibitors. In terms of mechanism of action, again, your anticholinergics inhibit parasympathetic receptors. These are your powerful motility inhibitors like Lomotil and Imodium over the counter. Lomotil is sort of like the prescription version of Imodium, and they're very effective. They will slow down your gut. They will just slow it down so stuff doesn't come out as fast, and if the stuff stays in there longer, you're going to reabsorb more water, but you also promote retention of whatever it was your body wants to get rid of. At the same time, anticholinergic side effects, these are body-wide. So we've talked about anticholinergic side effects before. They tend to give you dry mouth because they reduce salivation, blurred vision because they keep your pupils in a dilated state. It's harder to constrict them. Urinary retention because it blocks cholinergic-mediated bladder contraction. Anticholinergics tend to make you drowsy. They're just, you know, body-wide side effects. I mean, I'm not trying to make them sound like the devil. Sometimes you do need to use these. I mean, I'm sure we have all gone to work sometimes when we've had like this mass production jet-propelled diarrhea, and you can't get through the day without taking it. So, you know, you just take it and we all survive. But in the spirit of every drug is a poison, and we only want to use a drug when the benefit clearly outweighs the risks, we really should always consider the fact that if it's a day when you don't have to go to work and you can just lay around and have diarrhea all day, it's really the better thing to do because it lets the body excrete its thing that it doesn't want in there. When you take an anticholinergic, yes, the gut will slow down, but all of these other side effects will probably happen too. And because anticholinergics do suppress the central nervous system, they will interact with other drugs that are central nervous system depressants, like, like sleepers or alcohol or anything like that. They can potentiate tricyclic antidepressants and MAO inhibitors. These are drugs that we talked about, I believe, for using in use of depression. And they might elevate liver function tests, but every drug pretty much can potentially do that. So, if you're taking care of a patient and you're reviewing their labs in the morning and you see that their LFTs, ALT, AST, look a little bit elevated as compared to the day before, if they're on any medication, including these motility inhibitors, that's probably the cause of it. Now, one other thing before we leave the topic of diarrhea, which is a topic I'm sure we're all happy to leave. But before we leave the topic of diarrhea, there's also the probiotics. Probiotics are getting increasingly more widely used in the management of diarrhea. They really were originally designed to help with chronic diarrhea, like the chronic diarrhea of short gut syndrome or irritable bowel, inflammatory bowel disease. But more often you're seeing people prescribe them for acute diarrhea also. I really don't know how helpful they are, but these, you can usually get these as over the counter, like mixed in, yogurt and stuff like that. But their whole deal is that as a probiotic, they promote the healthy bacterial flora in the gut, because there is a theory that one of the causes of diarrhea is an imbalance between the good bacteria and the bad bacteria. So if you take good bacteria, if you purposefully ingest good bacteria, then you will promote GI health and normal motility and, normal bowel motility, normal bowel movement. So I do hear people say good things about them. I've heard lots, sorry about that. I've heard lots of patients say that they find them really helpful. I honestly don't have any personal experience with it. All right, the next group of drugs we have to talk about are those that are used to manage nausea and vomiting. So nausea and vomiting, two separate phenomenon. People do get nauseous without vomiting, and people do vomit without getting nauseous. If people vomit truly spontaneously with no nausea at all, that just needs to be referred to the attending right away, because they need a neuroconsult, because they have a pressure. Why can't I think of the word? They've got elevated intracranial pressure. They've got a brain problem, right? Most of the time, people either are nauseous and don't vomit, or they get nauseous and vomit. And that's typically what we wind up, giving meds for. So the way the whole vomit thing works is that you've got this area of your brain called the chemoreceptor trigger zone. And the chemoreceptor trigger zone is a functional area of the brain that will get stimulated. And if it gets stimulated above threshold, like if it gets stimulated to the point of producing a response, then the patient will vomit. And there are lots of things that can stimulate the chemoreceptor trigger zone. It can be flat out GI overdistension, like the stomach can just get so full. Especially if there's a motility problem in the stomach and it won't empty, the stomach can get so full that it needs to empty, and that will stimulate the chemoreceptor trigger zone. Some people, if they get they eat by virus or a bacteria, they ingest something bad. The same mechanism that can make you have diarrhea will also make you vomit. If your stomach, you eat some bad buffet, and your stomach knows it needs to get something out, you will develop this acute vomiting. And it depends on what you eat. If you eat something that's got staph infection in it, you're going to start vomiting in less than 6 hours. There's other things that you might not start vomiting for 24 hours. Just depends on how fast it multiplies in the gut and how quickly your gut becomes aware that there's something to empty. But so virus, bacteria, or even eating something that's not infectious, like ingesting something like people that have pica, they eat like baby powder and, I don't know, stuff that they're not supposed to eat. If you accidentally ingest, I don't know, like laundry soap or something, your body knows it needs to come out, you're going to start barfing. So this is stuff that can stimulate your chemoreceptor trigger zone. There's also, even certain thoughts can stimulate. Like everybody has that thing that if they look at it, they'll puke, or if they think about it. If you like step in dog crap, I don't know, like everybody's got their thing that upsets their chemoreceptor trigger zone. So this chemoreceptor trigger zone is this little functional area of the brain, and when it is stimulated to the point of threshold, then you'll vomit. Sometimes it gets stimulated almost, but not enough, because you also have inhibitory factors too. Like this zone processes a lot of input that wants to make you vomit, and then input that wants you not to vomit, because vomiting is not a natural phenomenon. Your body doesn't want to do it. It only does it when it has to. And usually your brain doesn't want you to vomit. Like some people like me just will do anything to avoid vomiting because we just like hate it. So just think about this area of your brain that is constantly balancing input to trigger vomiting and input to suppress it. If the triggers, it's like a seesaw. You've got triggers on one side and suppressors on the other. And normally they exist in a happy balance. But if your triggers get too high, well, then you're going to puke. But as your triggers go up, your suppressors will often go up, and it's like a war in your head. And any of you who have ever vomited, which I expect is everybody, knows what I'm talking about. Like, you know when you feel like you're going to puke, like whatever, you're sick, you woke up sick in the morning, you must have eaten something bad, or you don't feel good, and then something really nasty, like you see something really nasty, or you do step in that dog crap that's been there all night or whatever. And like your brain is feeling it. Your brain is like puke, 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 and you're thinking, no, I don't want to, and you're trying to suppress it. So you think about different things. You open a window, get cold air on your face, try to purposely like smell something good. I remember when I was a really little girl, my mother used to take me over to my great grandmother's house. My mom had to go help her clean it, and I don't know what the deal was. She died when I was really young, but I do know this house smelled so bad. It was a little apartment. It smelled so bad that every time I was forced to go in it, I wanted to puke. I thought I was going to puke. And my mother she would give me her lipstick thing, because I guess it was scented in some way, and I would sit there with her lipstick under my nose, trying to concentrate on the good smell to offset this nasty smell in the house so that I wouldn't puke. We've all been there. And then you've all been in that place where you know the battle's lost, you're going to vomit. So you've been putting it off, you woke up, you feel really pukey, you're like, oh God, I don't want to puke. So you open a window and you get up and you put water on your face, whatever you do, all those things to try to not think about it. And you can feel this battle going on in your head. It's like, do I puke? Do I not puke? And then something will happen. Either the suppressors will win and you've passed it. You may still feel nauseous, but puking is not imminent. You dodged a bullet this time. Or the triggers win and you pass the point of no return and you're going to puke. And you know how you know you're going to puke? Because your mouth starts to water. Once your mouth starts to water, that's the motor response. That's the response. The triggers have won. And when you are going to vomit, when you trigger a vomit response, it is a massive cholinergic stimulation. Your acetylcholine just rules the day and causes a whole variety of things that cause vomiting. And the first one is salivation. It's a massive cholinergic effect. If you can avoid salivating, you will probably avoid vomiting. But once your mouth starts to water, give it up and get a bucket or find a toilet or something, because you're done. That's the chemoreceptor trigger zone. Its job is to process all the input, and either you exceed threshold, in which case you're going to puke, or you dodge the bullet and suppress it, and then you don't puke. So one of the primary neurotransmitters that triggers the chemoreceptor trigger zone, one of the primary triggers is histamine. So I hit a wrong thing here and advanced the slide too soon, and now I can't go back to it. But before we leave the topic of histamine, just a reminder, we've talked about histamine in many different contexts in the first several lectures. It's a compound that does a lot of things, and it does serve as a neurotransmitter. Histamine is in the brain, and histamine 1 receptors are. It's got a lot of. Oh, good God! What's the word I want? I'm totally having word finding difficulties. Histamine has many roles as a trigger, as a neurotransmitter. One of them is that it's one of the neurotransmitters that will serve as a trigger or a stimulus for the chemoreceptor trigger zone. So it's one of the things that when you ingest a virus and your stomach knows you need to empty it by way of puking, it will fire off histamine to stimulate your chemoreceptor trigger zone and say, we need to empty, or whatever. If you think about something particularly nasty, histamine is one of the things that will trigger your chemoreceptor trigger zone and say, oh, she's got to puke, she's got to puke. The reason I mention histamine specifically is because it's one of the important triggers. It is the target of therapy sometimes when we are trying to control nausea and vomiting. Okay, so now coming on to the next slide that we appreciate here, when we look at specific drugs, again, you always want to use the least effective, or not least effective, you want to use the safest drug to produce the response that you want. So, I'm sure that you've had the experience of, on different occasions, you'll call different residents or different attendings to get orders for something for nausea and vomiting, and they'll give you different stuff. One will tell you to use Reglan, one will tell you to use Benadryl, one will tell you to use Vistaril, and then one will tell you to use Zofran or something like that. And, sometimes you wonder why. Why does this one use this or does that one use that? Are there different reasons or is it just personal preference? And the truth is it probably all falls into it. In a perfect world, any prescriber would use the drug that does the job that is the safest, that is the least, not least effective, but least insulting in terms of adverse effects. So that's why you'll see people use different drugs. Now, the pro-motility agents, and metoclopramide is really the only one we've got now. This is Reglan, and Reglan is ordered sometimes for nausea, less for vomiting, although you will see it ordered sometimes for vomiting, but certainly it is used as an anti-nausea agent, and the reason is that it accelerates GI motility. So this is an appropriate drug for somebody who is nauseous because their motility has slowed down and their gut is overdistended. So people who are immobile, people who are on opiates, people who are on other medications that slow down GI motility, if they start complaining of nausea, Reglan can actually help it because it enhances forward movement. It enhances motility of the gut. So it helps the stomach empty, it helps the intestines empty, and decreases that sense of nausea. Because of either GI stasis or GI overdistension. So it is very appropriate in that circumstance. It's totally inappropriate if somebody is nauseous or vomiting because they've eaten something bad, because they have a gastroenteritis and they're puking. If you give them a pro-motility agent to that patient, it will probably make it worse. So its mechanism of action is it stimulates the gut to move. And so when the nausea is presumed to be because of GI slowdown, that's when you'll see people prescribe metoclopramide or Reglan. And then we have drugs that suppress the chemoreceptor trigger zone. So there's a big difference here. The pro-motility agent of the last slide just treats the cause of one type of nausea. Drugs that suppress the chemoreceptor trigger zone, these are direct suppressants of the center of the brain that's going to make you vomit. That means these are the most effective. So if you have puked 5 times, if you're on like a every 45-minute puke schedule because you have viral gastroenteritis, these are the ones that's going to slow it down because these will suppress the chemoreceptor trigger zone regardless of the reason it's being triggered. Excuse me. So you'll find these to be the most effective. Conversely, they also have this highest side effect profile. They have the highest side effect profile because they work directly in the brain. So you probably know some of these. Some of them are really old school. Trimethobenzamide is Tygan. Prochlorperazine is Compazine. Droperidol is usually used with anesthesia. Ondansetron, this is Zofran, and this is most people's go-to drug for really, for significant vomiting. Ondansetron was originally designed for people that were on chemo, that had post-chemotherapy, like profound vomiting. That's how good it is. It's available in lots of different dose strengths, and for the people like on chemo now, they tend to get the higher doses, but it's come to common use for anybody who's vomiting for pretty much any reason when you want to stop it. I think it's the first go-to drug, ondansetron. It is available injectably. Injectably, is that a word? It's available in injectable form. It's available in sublingual form, where not really sublingual. It's called ODT, orally disintegrating tablets, and you just put it in the mouth and it dissolves. There are oral forms. I mean, it's always kind of tricky to take a PO anti-vomit drug, because if you're vomiting and it comes back out, it won't work. I can tell you from personal experience, the orally disintegrating type is amazing. I mean, even when you feel like it is almost imminent, you pop one of these things in your mouth and it can suppress vomiting from there on out. Of course, the downside is, there isn't a downside. When puke is on the horizon, you'll pretty much do anything to make it stop. But it often does make you tired, like those classic anticholinergic effects. But the chemoreceptor trigger zone drugs, those will suppress vomiting for pretty much any reason. Now, we also have H1 receptor antagonists. These block the action of histamine in the chemoreceptor trigger zone. Diphenhydramine is Benadryl. Hydroxyzine is Vistaril. Meclizine is Antivert, and I forget what the other ones are, but they all block the action of histamine. So if you remember that histamine is one of the triggers of the chemoreceptor trigger zone, it makes sense that if you block one of the triggers, you are less likely to vomit. So you've got the others, like a couple of others. Dronabinol is a THC-based compound. This is a weed-based compound, because that really does suppress nausea and vomiting. And then metoclopramide is the promotility agent we were talking about. And what it really comes down to is three primary drugs that you see used commonly for nausea and vomiting. Metoclopramide promotes motility, so that if you're nauseous because of GI stasis or GI overdistension, it will help. H1 receptor antagonists block one of the things that stimulates the chemoreceptor trigger zone, so it blocks one of the stimuli, and it is usually used to treat nausea. It's more used prophylactically, like post-operatively and stuff, or if you're on if you're going to do something like a ship, a cruise ship or a boat, or like motion sickness, that's the word I want. If you anticipate that you might be nauseous or vomit, H1 receptor antagonists are good. And then the chemoreceptor trigger zone suppressors, these are the ones that just shut down that zone regardless of the stimulus. So the CTZ suppressors are the most powerful. They're going to get the job done. Like if you're already vomiting, they're going to slow it down. The H1 receptor antagonist, they're preferable when you're worried about nausea or prophylaxis for nausea, because you don't want to shut down the whole zone just because you might get nauseous or just because you're a little nauseous. You want to shut down the zone if you've been puking nonstop for the last 6 hours. But if you just think you might be nauseous, or if you have a little nauseous post-op or post-anesthesia or something, H1 receptor antagonist is a good one, because it just doesn't alter normal physiology as much. And then the metoclopramide if your gut is static. And then dronabinol, again, the marijuana-based compounds, they're usually more specific, like to people with chemotherapy-induced nausea and vomiting and stuff like that. All right, so side effects. Whether we're talking H1 blocker or chemoreceptor trigger zone antagonist, either way, you are suppressing the central nervous system a bit, so side effects related to CNS depression. Most of the time, this isn't an issue, but if it's somebody who's taken a lot of the drug, or they're on other medications that present risk to suppress the central nervous system, well, then you do have to worry about things like hypotension, respiratory depression, etc. Anticholinergic effects are a given, because nausea and vomiting are usually cholinergic responses. So if you want to suppress them, you have to give anticholinergics. And then extrapyramidal effects. These are the potential concerns for people with that take the pro-motility agent Reglon. Again, most of the time it's fine. If there are people who have other risk factors for extrapyramidal symptoms, like they're on antipsychotics, for instance, then you do have to be watchful for those, like, extraneous tics and facial movements and stuff. But most of the time it's really not an issue. In terms of drug interactions, again, the H1 receptor antagonist and the chemoreceptor trigger zone suppressors, they are suppressing the central nervous system. So they're going to work hand in hand with other drugs that do those things. So these top 3 drug interactions, potentiates CNS depressants, potentiates anticholinergics, inhibits vasopressor, those are all other things that can suppress the central nervous system, and these drugs can too. So if you use them all together, yeah, you do, want to watch for like hypotension, respiratory depression, stuff like that. Especially some of the chemoreceptor trigger zone agents, and these are the older ones like compazine and Tigan, can suppress white blood cell formation and make the patient leukopenic or agranulocytosis and increase risk for infection. Again, usually not an issue in otherwise healthy people. If you already have immunosuppression and you have to give like a Zofran because they're puking, well, just, be watching that white blood cell count. And again, almost every drug under the sun can elevate liver enzymes. All right, now we're going to switch gears a little bit and talk about the medications that are used to manage peptic ulcer disease. And so again, always my primary interest here is patient education. And with peptic ulcer disease specifically, one of the questions that patients will ask you over and over again is, why am I taking antibiotics for peptic ulcer? Ulcer's not an infection. Ulcer's a hole in my stomach. Why am I taking antibiotics? So here's the deal. Peptic ulcer disease is a condition where patients develop ulcerations in that mucosal protective layer, either in their duodenum, which is usually where it is, or sometimes in the stomach, in the gastrum. But the fact is that the most common cause of peptic ulcer disease is a bacteria in the gut that kind of erodes that protective mucosal layer, and the bacteria is called H. pylori. So we do need to give antibiotics to treat patients with peptic ulcer disease. Now, there are some patients whose ulcers are caused by other things. Some people have acid problems. Some people have ulcers because they take non-steroidals, NSAIDs like ibuprofen or Aleve, and it eats away that mucosal layer. So there are patients that don't have a bacterial infection that causes their ulcer, but most of them do. The majority of patients with peptic ulcer disease do have a bacterial infection. So whenever we treat patients for ulcer, whatever the cause, whether it's a bacteria or something else, the treatment for peptic ulcer always involves 2 separate kinds of medications. The first, well, I shouldn't say that. Let me say that again. The treatment of peptic ulcer disease always involves 2 prongs or 2 considerations. One is to get rid of the thing that's causing the ulcer in the first place. And then 2 is to make the stomach less acid so that the ulcer that's already there can heal. Because, once an ulcer forms, then it's going to stay there because the acid environment of the gut keeps eating it away. So if you want to heal an ulcer, number 1, you have to make the stomach less acid so that the ulcer that's there gets a chance to heal, because it's not going to heal if you keep throwing acid on it, So you got to change the acidity of the gut to let the ulcer that's there heal, but you've also got to get rid of the cause. And if the cause is a bacteria, as it is the majority of the time, then we have to give antibiotics. So when patients say to you, why am I taking an antibiotic for a stomach ulcer? Ulcers aren't an infection. The answer is they're caused by a bacteria. So we will almost, not always, but almost always see antibiotics used to get rid of peptic ulcer disease. And the most common ones are listed here, and there's all different combinations of them. I mean, there's all sorts of commercial combinations put together, but it's usually some assembly of metronidazole, which you might know as Flagyl, clarithromycin, which you might know as Biaxin, tetracycline, which I guess you'll know as tetracycline, and amoxicillin, which you'll know as amoxicillin, or maybe Amoxil. Levofloxacin is known as Levaquin. So in order to get rid of the cause, you've got to give an antibiotic. I mean, you can just change the acid of the gut. You can give a drug that affects acidity, but if you don't get rid of the cause, the ulcer is just going to keep coming back. And then also Pepto-Bismol is used in the treatment of peptic ulcers because there are mild bacterial antibacterial properties there. So getting rid of the cause is number one. And if the cause is Helicobacter pylori, which it is most of the time, then patients will have to be on a course of antibiotics. This is a short-term thing. This isn't into infinity. Like any other bacteria, it's usually treated, oh gosh, there are regimens as short as 3 days and as long as 14 days, but you'll usually see these antibiotics given somewhere between 7 and 10 days. That's phase one. Now, at the same time, you do have to change the acid environment of the gut so that the ulcer that's already there can heal. Because once an ulcer forms, if there keeps being acid in the gut, then it just keeps eroding away that layer and it keeps burning the ulcer. So the drugs that we use to change the acidity of the gut are either proton pump inhibitors, PPIs, and you're probably familiar with them. They're very commonly used. Omeprazole, oh, I forget the brand names for these. Omeprazole, I forget how that's branded. Lansoprazole is branded as Prevacid. Pantoprazole is Protonix, and I forget the rest of them, but there's a bunch of them. They're all end in azole, and these are proton pump inhibitors, and they suppress the proton pump. Remember I said proton pump with a capital P, that thing that we looked at a couple of slides of the proton pump? These drugs just shut it down. They shut it down in any cycle. Basal phase, cephalic phase, gastric phase, digestive phase, whatever. These just shut down that pump. A lot like chemoreceptor trigger zone suppressors just suppress the chemoreceptor trigger zone no matter what's stimulating it. So the PPIs, or proton pump inhibitors, they are the most powerful, most effective drugs that we have to suppress acid production and therefore raise the pH of the stomach. And duodenum as well. Mechanism of action, well, they inhibit the proton pump. That's why they're called proton pump inhibitors. So you will have decreased gastric acid production at any time in the series. Excuse me, again, those 4 phases we talked about. And what this does is decrease the acidity, raising the pH of the gut and providing a more neutral environment for healing. Now, we also have H2 receptor blockers or histamine receptor antagonists. Let me see if I can remember the names of these. Cimetidine is marketed as Tagamet. Famotidine is marketed as Pepcid. Famotidine is marketed as Pepcid. Nizatidine is marketed as Axid. And ranitidine is marketed as Zantac. So, Tagamet, what did I just say? Tagamet, Pepcid, Axid, and Zantac. That's as they appear here. So they block histamine receptors, H2 receptors. And remember that histamine receptors or histamine is the primary trigger that turns on the proton pump in that basal phase, in that interdigestive phase when you are sleeping. So the difference between proton pump inhibitors and H2 blockers is that proton pump inhibitors will suppress the proton pump at any time in the cycle, no matter what the trigger is. H2 blockers block one of the things that triggers the proton pump, and that thing is histamine, and that thing, histamine, is most predominant during the basal phase. So H2 receptor antagonists like Zantac, Pepcid, etc. are more likely to suppress the proton pump during that basal phase, like the overnight hours when you're sleeping. So these work a little bit differently. These just don't shut down the proton pump no matter what. These inhibit binding of histamine at the receptor sites on those parietal cells, those cells where the proton pumps are located. So it inhibits the binding sites, that reduces pumping of hydrogen ions. It reduces acid output. It doesn't suppress it in the same way or intensity as a proton pump inhibitor does. So there's like a real analogy here. The proton pump inhibitors are to the proton pump what the chemoreceptor trigger zone agents are to the chemoreceptor trigger zone. They just suppress these babies no matter what. They're the most powerful, the most efficacious. H1 receptor antagonist in the brain and H2 receptor antagonist in the gut are the second most efficacious. They block the action of an important stimulus for the proton pump, just like H1 blockers block an important stimulus for the chemoreceptor trigger zone, but they just don't have as much oomph as the PPIs, which means they don't alter normal physiology as much as the PPIs, which means when you can use the H2 blockers, it's preferable because you always want to use the drug that affects normal physiology in the least offensive way. Does that make sense? Let's say it one more time just to make sure it does. There are two ways to decrease acidity of the gut. The proton pump inhibitor is like the bomb. You know, this one will suppress that proton pump no matter what. It'll suppress that pump in all four phases: basal, cephalic, gastric, and digestive. And it just suppresses it no matter what's turning it on. I mean, it decreases acid output, period. The H2 receptor antagonist block histamine. And histamine is an important trigger of the proton pump in the basal phase. So you can see H2 blockers, they're not as powerful as the proton pump inhibitors, which makes them preferable when they will do the job that you need them to do. Now, sometimes you're not strong enough, you need a proton pump inhibitor. But when you can use a PPI, you should. So that's that. And they also decrease acid output, but primarily during that basal phase. Now we can't forget, before I go there, there are some side effects to the H2 receptor antagonist, and they are listed here. Not as profound as the proton pump inhibitors, but I mean anything that interferes with GI physiology is going to cause potentially abdominal discomfort and diarrhea. Now these are H2 blockers, so they don't have nearly as much oomph in the brain as the H1 blockers we talked about a little while ago, but there is some crossover of the blood-brain barrier, so there is the potential for drowsiness, a little confusion. In fact, cimetidine used to be well known for confusion. It's really not that big of a deal, but it can happen, usually people who are otherwise at risk. Now, this is the slide I thought we were going to. The mucosal protective agents. We can't forget carafate. Carafate, the generic name is sucralfate, and this has a totally different way of treating ulcer disease. Sucralfate doesn't change the acidity of the gut at all. What it does is form this paste-like substance that sort of fits into the ulcerated area and makes a mechanical barrier. So in other words, if you're just going along the gut and you see one little ulcerated area, carafate makes a paste, plunks itself in that ulcerated area, and it protects it from acid irritation. So it helps it heal that way. Sucralfate is different than all of the other drugs that help an existing ulcer to heal because it doesn't change the acidity of the gut. And this is preferable because, you know, remember, the pH of the gut is between 4 and 5 for a reason. And that reason is that is the pH at which ingested nutrients are best metabolized for absorption. So of course you want to not manipulate the pH of the gut when you can help it. Now, if you have a patient who has a condition where you just have to change the pH of the gut with a proton pump inhibitor or an H2 blocker, then you have to. That's all you can do. But if you can use carafate, the advantage of carafate, aka sucralfate, is that it doesn't alter the natural acidity of the gut. Remember, the compelling thing always is don't interfere with normal physiology if you can help it. Now, the downside of carafate, and there are a lot of them, you know, the upside is it doesn't change the pH of the gut. The downside is that its job is to bind to these ulcerated areas. These are binders. They'll bind everything. If there's other medications in the gut, it'll bind them too. If there's vitamins and nutrients in the gut, it'll bind them too. So it can really interfere with the absorption of some important things. So carafate should always be given on an empty stomach. The other problem is you have to give it several times a day. I mean, in an ideal world, it should be given 4 times a day. So if you give it 4 times a day on an empty stomach, like there really isn't much time left to eat. So it's really inconvenient and difficult to give properly. And for that reason, we don't use it a whole lot. But like if the patient is otherwise NPO, or you can control their intake tightly. Carafate is just nice because it doesn't change the normal pH of the gut. So these are some of the different drugs that we use. Now, how do they get used? Well, that's what the next things are for. So now we use them for different diseases, right? Now, gastroesophageal reflux disease is GERD. This is not an ulcer. Patients with GERD don't have ulcers. They have an entirely different problem. They have a problem where, for whatever reason, the contents of their stomach is refluxing into their esophagus. So if you remember that the contents of the stomach is very acidic, and the esophagus is not designed for an acid environment. Remember, the stomach and the duodenum have that mucosal barrier to protect them from acid, but the esophagus doesn't. So if you take something that's very acidic in the gut, like bile, which has a pH of 4, and put it into the esophagus, which isn't designed for that, it's going to burn. And this is what heartburn is. The proper name is pyrosis, but we just call it heartburn. And the problem there is that it literally burns the esophagus. It's throwing acid on a sensitive surface. So gastroesophageal reflux disease, that's what it is. The primary drug of choice for this is a proton pump inhibitor because proton pump inhibitors raise the pH of the stomach contents. So now if the stomach contents refluxes on the esophagus, it doesn't burn it. So unlike peptic ulcer disease, where you can use Carafate or you can use an H2 blocker to protect the gut, with gastroesophageal reflux disease, the drug of choice is a proton pump inhibitor, and it's really important that it be given at least an hour before the first meal of the day. And you can understand the reason for that if you think back to those 4 phases of gastric acid production. Remember the basal phase, the cephalic phase, the gastric phase, and the digestive phase, or the intestinal phase. So remember that in the basal phase, your proton pumps are only working at 30% maximal output. And then in the cephalic and gastric phases, that's when gastric acid output really cranks up. So if you give a proton pump inhibitor, you want to be suppressing these pumps during their maximal efficacy. You want to shut them down during the gastric phase primarily. So if you want to shut them down during the gastric phase, you have to give this drug in time that it is swallowed, broken down, absorbed, and distributed in blood at such a time that its maximal efficacy will be during the gastric phase. Like if you take this drug with food, by the time it actually reaches a peak serum level, you're in the intestinal phase. You're digesting. Your proton pumps are at 10% their maximal output. You're like closing a door that's already closed. Can't take proton pump inhibitors with food. They won't work. They won't do any good. If you take them at least an hour before the first meal of the day, then by the time they are absorbed and reach their serum peak, that's about the time you are eating. So they reach their maximal efficacy at the time that your gastric acid pumps are at their maximal production. So that's why if patients say their proton pump inhibitors aren't working, guarantee you they're not taking them right. And then, yes, the recommendation is if you give them at least an hour before breakfast and they're taken properly and they still don't work, then we give a second dose at least an hour before dinner. But a really important piece of giving proton pump inhibitors, especially for GERD, is that they should be given about an hour before a meal so that by the time they reach their serum peak, that's when the pumps are really cranking out acid. All right, shifting gears here a little bit. Remember I was talking about irritable bowel syndrome, and I said it was a functional motility disorder. It is strictly about the gut either moving too fast or moving too slow. If the gut is moving too slow, the patient will have constipation. If the gut is moving too fast, the patient will have diarrhea. And that's all there is to it. It doesn't have anything to do with anything else in the body. So by the time the patient gets a diagnosis of IBS, every other cause of constipation and diarrhea should have been ruled out. I think I mentioned this before, excuse me, but there are 3 types of irritable bowel syndrome: IBS constipation, IBS diarrhea, and then IBS combination. Some people call it IBS mixed, some call it IBS undifferentiated. There's just, these poor souls are just like, they can have diarrhea and it alternates. Like, for a couple of weeks, they will be constipated, can't have a bowel movement once every 5 days if they're lucky, and then boom, they just suddenly switch into irritable bowel diarrhea, and their diarrhea is so bad that they can't even leave the house. Like, they're really afraid to get in the car for like a half an hour ride or something in case they get a stimulus to stool. It can be really distressing, but it is just in the gut, doesn't affect the rest of the body at all. There are, and this, I'm sure that you probably aren't focusing as much on this, but the symptoms are primarily in the gut. This is a gut problem. This does not affect the rest of the body. So you can see everything here is about the gut. And these people will often complain of like this crampy abdominal discomfort, and sometimes it's really bad. They're bloated. Their focus is totally on their gut. Now, I also mentioned this a little bit earlier. There are a couple of different neurotransmitters that stimulate GI motility. We've talked a lot about acetylcholine, and that's an important one. The other important one is serotonin. I don't know if you remember this from your patho classes or not, but the gut is kind of unique from the rest of the body in that the gastrointestinal system has its own whole entirely separate nervous system. It's called the enteric nervous system, and the whole thing is embedded and lives in the muscle of the gut. The gut can function even if it is totally cut off from the rest of the body. And that's by way of the enteric nervous system. It's not perfect, but it can keep the gut moving, even if like the patient has to have a vagotomy, and they have like surgical severance from the rest of the nervous system. The gut can totally move on its own. And the primary neurotransmitter there is serotonin. So the primary neurotransmitter from the autonomic nervous system, which is the central nervous system stimulus for the gut, is acetylcholine. The primary neurotransmitter from the enteric nervous system is serotonin. Now, usually in the healthy patient, both acetylcholine and serotonin work together to maintain a normal GI motility. But in some people, people that have irritable bowel syndrome, the belief is that the primary problem is a serotonin abnormality. Serotonin, it's either not active enough or too much. So we always use medications from least offensive, least toxic, etc. So early on, like with patients that just have mild symptoms of IBS diarrhea or IBS constipation, the treatment of choice is bulk forming laxatives. And I know that sounds counterintuitive with diarrhea, but not really. These are things like Metamucil, and Fibricon and stuff like that. And in diarrhea, they will bulk up the stool and suck in the water. In constipation, these drugs actually like grab water from the GI environment. They distend the gut and can increase motility that way. It's kind of like a rubber band. If you stretch it, it will snap back. And that's the way the gut is too. So for patients with the most mild of symptoms for IBS, we always start them out on bulk forming laxatives. So don't be surprised when you see it prescribed for people that either have diarrhea or constipation. It can work for both. In diarrhea, like I said, it sucks in the water and forms things up a bit. And in constipation, it can also suck up water, which increases the bulk of the stool, distends the smooth muscle of the gut, and can result in rebound contraction. So yeah, Metamucil, Citracel, Fibricon, there's a ton of them. Another important thing, again, from a patient education perspective, is to tell patients no insoluble fibers on an empty stomach when they have irritable bowel syndrome. Dietary management is a big part of irritable bowel syndrome, and insoluble fibers are fibers that sit in the gut, but they can't draw in water. These are things like peels from a fruit, like orange. People don't eat orange peels. What am I thinking of here? Help me. Apples. Apple rind. Like, you don't want people eating apples on an empty stomach without like taking the skin off. Stuff that doesn't absorb water. Soluble fibers are fibers that can absorb water, like breads, and they're very appropriate. They're a good dietary strategy. They're like natural Metamucil, but no insoluble fibers, no fibers that can't draw water in. The next level of medication that you actually will see prescribed for irritable bowel syndrome are tricyclic antidepressants and selective serotonin reuptake inhibitors. And you're probably thinking, but they're antidepressants. Why are they being used for IBS? Well, there's a couple reasons. There's an old school of thought that says people with IBS may have sort of an anxiety component, but that's really kind of outdated. But now recognizing that serotonin is a primary driver of the gut, tricyclic antidepressants and SSRIs may actually help modulate the amount of serotonin in the gut to make it normal. I mean, either way, if with IBS-D there's too much and with IBS-C there's not enough, tricyclic antidepressants and SSRIs are believed to modulate the extremes so that you get a more normal amount of serotonin in the gut and will normalize GI motility that way. That's the theory anyway. The most powerful drugs that manage irritable bowel are typically those that directly affect serotonin. So the management of IBS-C, the best, most effective drugs are the serotonin agonists. 5-HT is scientific notation for serotonin. And serotonin 4 receptors are those specific to the bowel. Serotonin agonists are very effective in stimulating the gut, but there are none currently available in the United States. I mean, they're working on it. What was the name of that one? I can't think of it. There was one that we used to have, a Zelnorm. It was branded as Zelnorm, and it was extremely effective medication for IBS-C. But there was this associated cardiovascular risk, and so it finally got pulled from the market, so we can't use that anymore. Now, probably the most powerful drug that we have for IBS constipation is lubiprostone. It's marketed as Amitiza, and what it does is really like just pulls water into the gut. It's a chloride channel block, and well, next page probably tells you, or next slide rather, yeah. It is a chloride channel activator. It pulls water into the gut to increase motility that way. But it is really meant primarily for people with IBS-C, because this constipation can be profound. You will see it used for opiate-induced constipation and constipation of other forms, but like stand by, because it's pretty powerful stuff. Interestingly, some patients do report benign chest tightness or shortness of breath when they take it, but this usually goes away within a couple hours of administration and is not clinically relevant. However, because this occurs, a lot of prescribers don't like to use it in people that have like coronary artery disease or, conditions that can predispose them to cardiogenic chest pain. But don't be overly concerned if somebody with no cardiac history and no cardiac risk tells you that they get chest tightness after they take it. That is an observed phenomenon with Amitiza. Makes you go poops though. Then we have management of irritable bowel syndrome diarrhea. So these people, like I'm telling you, they sometimes their diarrhea is so bad they can't leave the house. In fact, there's a really cute commercial on TV right now. I can't think of the name of the drug, which I guess means it's not that good of a commercial. Maybe I'll think of it before I'm done talking about it. But the commercial is like, there's this young woman, and then her alter ego is there with her. And her alter ego is like her with red hair and blue eyes. And she's wearing a nude bodysuit with an intestine painted on it. I know some of you have seen this commercial. So like this woman is at work and like they're calling her to go to a meeting and she's trying to go. And then her alter ego, who is the bowel, is saying, you can't go. You have to go to the bathroom. So she's like, oh, start the meeting without me. And then she goes to the bathroom and have diarrhea. And then like in another scene, she's like trying to go window shopping and her alter ego bowel is like, no, we have to run off to the bathroom. So finally she like wises up and she makes an appointment with her doctor and she goes in to get treated for it. So she's sitting on the exam table and her alter ego is sitting there pouting, because she's not happy about it getting treated. So this drug, I can't believe I can't think of the name of it. It's really a bad commercial if you can't remember the name of the drug. But anyway, I'm sure you'll look it up after you listen to this or something. But that is a drug that stimulates GI motility, and it is a serotonin agonist. That's one option. Obviously, since I can't even remember the name of it, it's not named here on your slide. Other options for stimulating GI motility are probiotics. We talked about probiotics in the management of diarrhea a little bit earlier. This probably isn't the most effective thing if, like, the patient is having, 15 watery jet-propelled stools a day. But for people that have irritable bowel diarrhea, probiotics may be helpful. We talked about the classic antidiarrheals like Lomotil and Imodium. Do be careful, like if they're being administered to somebody who has chronic diarrhea, you just want to be careful that they don't get overly constipated, that they don't, these drugs will slow down your gut for sure. And if you have like acute diarrhea, that's fine. But for people with IBS-D, they could switch into IBS-C at any time. And if you're giving them Lomotil or something, that could really exacerbate their diarrhea. Rifaximin it's actually in the rifampin family, and this also is used rarely. I mean, you'll probably never see it, but it's here for the sake of completeness. Now, Lotranex is a drug that is now on like controlled delivery. Like, it's not given very often. It's given for very profound IBS-D. And this is a serotonin receptor antagonist. So remember I said serotonin is like the primary culprit of irritable bowel, constipation, and diarrhea. So Lotranex, it will slow things down. The patient will stop having diarrhea. In fact, for some people, it slowed down things so much that they developed ischemic colitis and toxic megacolon, and then their guts blew up and they died of sepsis. So the drug was removed from widespread market distribution. Now it is available for people that have a very defined need, and they have to do a little educational course and sign a thing, and even the prescriber has to sign a thing, and it's a big deal. So if you ever have a patient who's on Lotranex, be extremely aware of the potential for sudden diarrhea or sudden bowel symptoms. This is only used, though, for the most extremist of people with irritable bowel syndrome. And then finally, for the last couple of slides, these are drugs that are used to manage inflammatory bowel disease. Remember I said inflammatory bowel disease is different from irritable bowel syndrome. Inflammatory bowel disease is autoimmune. The patient makes antibodies that ultimately result in ulceration of their bowel or just their colon. And so there's a couple different types of therapy for it, but the monoclonal antibodies, the immunomodulators, also called tumor necrosis factor alpha inflammatory mediators, these are the most powerful. These actually try to attenuate the autoimmune process that is causing ulceration in the gut. And there's several of them listed here. Remicade, Humira, they've been around forever. Cimzia is a little bit newer, but this whole class of drug has been around for a long time. The primary safety issue with these is immune suppression. These drugs are immune system suppressors. So people who take them are at higher risk of infection. They're at higher risk of the expression of cancers. If they have occult TB or controlled hepatitis, and then they take these drugs, those diseases can become more fulminant. So before patients are even started on them, they are worked up for latent infectious diseases. But you always want to be really aware in patients who are on these TNF alphas of the risk of infection. If they show up with something like herpes zoster or hepatitis, the drug has to be immediately discontinued. Or even if they're just really sick, the drug has to be discontinued. They're very powerful in the suppression of inflammatory bowel disease because they're very powerful in the suppression of the immune system in general. So like your handout says, the trend is to use these earlier in therapy, so you'll probably see people on them. And hopefully what you will see are attendings and residents who are really attentive to their immune system. If you have patients that are on TNF alpha modulators and they suddenly develop infection, you do want to draw the resident's attention right away to the fact that they are on TNF inhibitors and, think about holding those drugs. Now, these older drugs, these are anti-inflammatories whose goal is to work in the gut. These are not systemically absorbed. You either take these as a pill or insert them as a suppository. Pentasa, Roasa, and Asacol. been around forever, and keeping in mind that we're talking about inflammatory bowel disease, these are anti-inflammatories. So again, they don't have nearly the potential for side effects as the TNF-alpha drugs, but they also don't have nearly the effects. So these are for more mild cases of inflammatory bowel disease. And now we also have Lialda, which is another drug amongst this class. It's available for once daily therapy. So it's really just about suppressing inflammation, whether you give an anti-inflammatory like these drugs or you suppress the immune system in general. There's actually a whole escalation. There's like a whole task force on inflammatory bowel diseases, and it does include things like diet and stuff like that. But at the end of the road, these are autoimmune diseases, and really the most powerful way to treat them is to suppress the immune system. So you have to be watchful for side effects of expressed disease. So that's all I got. As always, I hope it's helpful. And if you have any questions, please do hit me up. Otherwise, I'll see you next week or talk to you next week.